I'm Steve TePastte. I have had myasthenia gravis for a little less than 2 years. In fact, in just short of 2 months, I will celebrate the anniversary of my admission into the neurointensive care unit at Sparrow Hospital in a myasthenic crisis, fending off a ventilator. I was a family practitioner in a little place called Holt near Lansing, Michigan for many, many years, and I loved it. I was also a medical director of the the teachers, Michigan State Teachers Union, and my job there was to speak on wellness. So I love speaking, I love talking with patients, I love medicine, and this opportunity to kind of reflect on my years in myasthenia gravis, and I'm going to go over my story. It's compelling to me. I'm sure others in the audience have at least as compelling a story, but it will serve as sort of a way to intro me into what I'd like to talk about. I'm actually going to talk about the meds, the old meds and the new meds. I can do so because even though I'm not a neurologist, neuro-ophthalmologist, research scientist, I speak the lingo. I love reading. I love researching. I read the journals. I've been a participant in webinars. And so I think I'm kind of ready to at least present my thoughts. These are simply my thoughts. They're not suggestions for care. And then the final part, and is kind of to me, the key part of this is really how to truly live your life. You know, medications are important, but what we're going to talk about is conducting your life to live the best possible way you can with myasthenia gravis. So in 1998, I was on my way to the athletic facility to ride my bike, and on the way there, I saw cars like this. I saw too many cars. I got out of my car. For some silly reason, I thought I could still ride my bike holding one eye closed. That's not going to work. I called my wife. This is not okay. So that's how it started with my seeing double. I went to a local ophthalmologist, and he kind of gave me unsatisfying answers like, it's just my weak muscles, it'll be fine. And I knew that wasn't the case. I was wandering around in that facility, and I bumped into a neurologist, and he could see I was having an issue holding one hand over an eye. So he took me over in care. He gave me an exam. And the first thought is brain tumor versus stroke, which is certainly possible. And I'm rattling around in that MRI machine thinking, what would I rather have, a brain tumor or stroke? Neither are good. It turned out, fortunately, I did have neither. So that was a relief. But over the next just very few days, all the other stuff started happening, like ptosis, my eyes drooping. I couldn't smile. My face was frozen. I couldn't speak. Those were not good. And by this time, my smart neurologist had kind of figured out it's probably myasthenia gravis. He drew my blood for the AChR antibody test. But back then, 25 years ago, it takes a while. It went to mail. We didn't know. So he put me on Mestinon and tried that for me, but it wasn't working. I got worse. I couldn't chew, I couldn't swallow. And then I realized there was more to it than that. And my muscles in general were not working. It wasn't just my face and swallowing, it was my whole body. And I found myself sitting in a chair, and I found myself not being able to get out of that chair, which isn't good. And then I found myself not being able to breathe, which is desperately not okay. So my wife and I are off to ER. And so 12/14/1998 was my myasthenic crisis. I actually, in the emergency room beforehand, got the tensilon test. That's this intense form of similar to pyrostiamine called edrophonium. And as a test to see if I had myasthenia gravis, because my medicine wasn't working and my lab test wasn't back. And that was magical. So by the way, you need IV anesthesia for that. It's really dangerous, and it's not done much anymore. But it was positive, and so I got admitted in myasthenic crisis. And I did what managed by sneaking around the rules and only having them test my breathing capacity when I had major jolts of IV pyrostiamine and IV steroids and IVIG. I managed not to get on a ventilator. Then I slowly recovered. But when the test came back, I knew I had MG. So what has happened was, and now I look back and I'm thinking, a couple of weeks ago, we went to North Carolina. My daughter wanted to try to go to UNC Chapel Hill, which she did eventually go to. And I was a runner back then, and I went for a really long run back 25 years ago. I didn't have a cell phone. I don't know if I had one then or not, but I didn't have one. And I got lost. And instead of a 5-mile run, it was probably a 25-mile run. So I exhausted myself. And then on the plane ride back, I think I caught RSV, as nasty respiratory virus. So I had all the kind of requirements of infection and stress to form an adverse antibody. So my body made a mistake, and my immune system formed an antibody against my own healthy tissue, which is called acetylcholine receptors. Why me? And by the way, why me so fast? How do you get from feeling fine to being often almost on a ventilator in 3 or 4 days? I think I just go through everything too fast. But clearly, my immune system made a mistake. The immune system is a wonderful thing. B cells are a kind of lymphocyte that make antibodies. They make very specific antibodies. That's why vaccines work, because they make an exact antibody to attach to that whatever virus or bacterium that you're fighting off and identifying it. And B cells are made in the bone marrow, hence the word B, and they mature there, then they go all around our body and fight. So they're fantastic, but because my immune system thought the RSV was my healthy acetylcholine receptors, it formed an antibody against them. And then there's this thing called a thymus. This thymus is an organ in your chest. When you're a little kid and an infant, it's pretty big. It's another kind of lymphocyte. They're called T cells because they go to the thymus to get matured. And the job of the thymus is to mature them and they support B cells. So, and they're just as specific as B cells. So when you get a virus, bacteria, or a foreign invader of some sort, the B cells will attach, and the smart T cells that are directly related will destroy them. So my thymus was broke. It was kind of like not doing its job, and it was not only not helping, it was actually worsening the problem. So I needed to stop the attack on my myosin acceptor receptors. 25 years ago, we didn't have the newer drugs now, which are more focal and less dangerous as far as damaging our immune system. All we could do is blast our immune system and make it less effective overall. The way it works at the neuromuscular junction, which is this tiny microscopic part of our body which connects muscle and nerves for skeletal muscle, the muscles that move all your extremities and such, is the nerve terminal ends, and that's nerve tissue. And then the nerve sputes out this chemical. So the nerve is electrical, but the connection is chemical, and the chemical is called acetylcholine, and it drips from the neurons onto the muscle receptors. And I stress the word muscle because muscle regrows. And so before you attack the acetylcholine receptor antibodies, they will destroy your muscle receptors, and there's all kinds of other components to destroying tissue once the antibodies and T cells have figured it out. And so it can really damage your neuromuscular junction, and you are weak. So there's a really good drug called pyridostigmine or mastodon that if you have mild MG, or even if you don't have so mild MG, it can often help. And I was on it for quite a while, but it was just intolerable. I have irritable bowel syndrome, and now I had irritable bowel syndrome on steroids, even though I wasn't on steroids yet. And I just could not tolerate it, and I didn't find it all that helpful. I was trying to stay as active as possible and working in my time frame around mastodon, but it didn't work, and this wasn't going to help. So we had to suppress my immune system. So I had this wonderful partnership with this fine MSU doctor. And by the way, I went to MSU. I actually got an undergraduate there at MSU. Then I went over to Northwestern and got a degree in social psychology, whatever that is. And then I realized I don't want to be whatever that is. So I went back to MSU, took courses to go to med school, worked as an orderly at Sparrow Hospital, went to med school, went to residency at Sparrow Hospital. So I'm very locally Michigan State related, and worked there in the Lansing area. So, as did my neurologist. So back 25 years ago, we had prednisone, and we used high-dose prednisone. And we took the initiative to jumpstart with the plasmapheresis. Plasmapheresis is the way to eliminate the plasma from your blood. Your blood's got the red cell component, so that's what makes it red, with hemoglobin and components of red cells, masses. And then it has the plasma, which has all the other good stuff that blood transmits all over our body, including all the antibodies. So you're just actually wiping away all that plasma, replacing with albumin. And it's sort of dangerous, but it seems in the short haul to be safe and effective. And that was our plan. It worked, and I was I was not the most patient of people, as I've never been the most patient of people, but I was on super high dose prednisone, then lots of plasmaphereses, and in 4 weeks, my double vision stopped, which was a great blessing because wearing patches and those prism glasses were most unpleasant. 6 weeks before I could walk. So I was pretty impaired at that time. 2 months before I could go back to work, which was very important. 3 months before I could bicycle, which is extremely important. And finally, 6 months before I felt like I was back, my eyes stopped drooping. And from that point forward, as many of you know, it relapses and remits, it fluctuates. And I remember Halloween in 2002. I remember going back on plasmapheresis and high-dose prednisone, getting the Charlie Brown face and weight gain. 2005, 2006. 2006 was said, that's when my mommy passed. And I was stuck in bed, and I couldn't get to be with her as I wanted to, at least as soon as I wanted to. It did turn out over for me, and I think for most of us, as time went on, as years go by, as you get smarter, your IVIG usage isn't as much. Now, I switched from plasmapheresis to IVIG because I was out playing golf, and I hit the ball and I missed it. I hit the ground, and my arm swelled up like a sausage. The plasmapheresis requires these central catheters, and mine was in my subclavian vein, and I clotted it off. So I had a big clot in my subclavian vein, which is a very serious medical problem, which if you don't address, if that material inside that vein broke off, its ending spot is your lung. That's called a pulmonary embolus, and it would have been a very big clot. It could have been lethal. So I was stuck on I'm stuck on blood thinners for years, and I've avoided plasmapheresis since then. After I got better, a couple of years later, because you have to sort of calm down, it turns out, back then we weren't sure, but now studies have shown that if you're under age 50 and you're AChR positive, having your thymus removed, and back then they did it, they cut my sternum, and I have wires in there. Now they can do it endoscopically and quicker. That because your thymus is a bad policeman and doing it make things worse, removing it actually truly helps. So I did find, up and down. There were some times when I knew I had some mild myasthenic symptoms, but I did find my relapse was 7/13/2021, and it was my own fault. I knew not to go ride my bike on the Lansing River Trail because it looked like it was going to rain. I knew that if it really started raining, I should get off. I did not. And my skinny road bike went over a bridge with these skinny wooden planks. And I can't tell you exactly what happened, except somebody found me at the bottom. I think I fell while on my bike over and over again. 5 pelvic fractures. In fact, my pelvis was unstable, and rib fractures and a brain hemorrhage. I was in Sparrow Hospital for 6 weeks, in a wheelchair for 14 weeks. But this is a really important lesson I want to pass on. And I realize this is a bit easier for me as a doctor, but it's still very, very important. The nice doctor who was the orthopedic surgeon on call was a bit eccentric, and he didn't like seeing patients. He had his residents see patients. He just did operations. The residents came by a couple of times, and they finally said, TePastte, you're not that young, and you have myasthenia gravis. So we think we're just going to leave it as is and not fix it. And I said, no, you're not. I want to speak to this Dr. T, we'll call him. And I am not that old. I have no other things wrong with me. I will endeavor to work as hard as possible to recover. And I can handle my myasthenia gravis. This is a treatable disease, and I can be well again. So I never did see the guy, but the residents prepped me for surgery. I met actually Dr. T for a few seconds before surgery, but he put two titanium screws and reattached my sacrum, and I'm back walking. So that's kind of the important message there is asserting yourself, acknowledging that you have something, but it is not a reason not to have things done. And there is good news for myasthenia gravis. I mean, we are in a modern era now. It was a terrible disease up until the 80s. Deaths are very rare. Most everyone gets great help. There's newer MG meds, which we're going to talk about. And almost everyone can have a full or nearly full recovery. Now, I know there's some that are still struggling, but we are still making progress in this disease, and I'm hopeful for everyone. So, as I had to demonstrate with my being silly enough to ride my bike in the rain over a wooden bridge and breaking my pelvis, nonetheless, you have to take charge of your MG, you have to take charge of your life. So let's talk about the pills. My pill is prednisone, and it's a nasty pill. It's incredibly effective. Of all the myasthenia gravis, it's actually the most effective if you can take it, and your body will allow you to, and you don't have adverse life events or medical conditions that prevent you. Of course, it causes weight gain and therefore diabetes, therefore high blood pressure. It can make you moody, cranky, keep you up at night, thins your bones, messes up your eyes. So I think this is, in my humble opinion, if you work hard enough, you can overcome these things and use this valuable drug, which almost all of us are on it to some extent. So what do? If you're on prednisone, you firstly need to have a really effective relationship with your doctor to safely reduce your baseline. The doctor, in most cases, except actually that's you and your doctor together can figure this out, but you have to do your homework first and make sure you're on the same exact scientific togetherness to make sure you're doing it right. Everyone on prednisone for any length of time needs to have A1Cs. A1Cs are just simple blood tests that average your blood sugar over 3 or 4 months. Normal is 5.7 or less. Pre-diabetes, 5.7 to 6.4. Diabetes, 6.5 and higher, the higher the worse. And this is so common that all of us need to know what our A1Cs are. And on the topic of diabetes and risk factors for heart disease, you need to know your cholesterols. You need to know your numbers. You need to know how to interpret your numbers. You need to know what your numbers should be. And everyone should know their blood pressures. And I may always tell my patients to measure your blood pressure at home. They come in the office and they're sort of nervous and the blood pressures are sort of high. They may be real, but the real blood pressure is the one you take at home. Home blood pressure monitoring is easy, safe, and cheap. And you measure your bones. So the standard these days for just the average person is 65 women, 70 men. If you're on prednisone for 10 years, you get bone densities. There's treatments for thin bones. Thin bones lead to fractures, which are devastating. And you need regular eye exams. And what you really need to do, and this is hard, and this is something I'm not perfect at, but I work really, really hard at, is you have to restrict your calories. I did talks on what's called the basic science of weight loss for the teachers' organizations. Exercise is great, and I'm big into it, but it's calorie restriction. And the easiest way to do that, the simplest way to do that, it's not easy, is fruits and vegetables and virtually nothing else. I mean, it takes more calories to eat most vegetables than are in them. And they're fantastically wonderful for you too, and whole foods are wonderful for you too. Fitness regimens is important. Avoiding processed foods is important. And basically monitoring your weight for the time you're on prednisone, which is the rest of our lives by and large. But that's not for everybody. Prednisone has worked for me. And I did a lot of this research on these newer meds because it may not always work for me. And I may want to consider other treatments. But I also feel a connection now with MIMG. I want to be a part of this organization. I want to help others as well. So I want to learn as much as I possibly can. Back in the time when I was on prednisone and I was on high doses for long periods of time, they did suggest immunosuppressants, the old school ones like Imuran, Cellcept, methotrexate, cyclosporine. In my reading, I wasn't that enthused. They take a long time to work, up to a year. They do increase your risk of cancers, especially lymphoid, leukemia, and skin cancers. And I wanted to live a long time, and I didn't want to have to deal with that. So other people have done that, and it can be something necessary if you can't get your prednisone dose down, you can't tolerate it. But now we got, the Imuran, Cellcept, et al. Are kind of, and to some extent, prednisone are sort of like little sledgehammers that bang down your immune system, because we have this one aberrant antibody called AChR receptor antibody, and we'd like to just be able to knock that one down and leave the rest of the immune system alone. And those old-fashioned ones knock the whole immune system down. The newer ones are better. One that's not great but is better is rituximab or Rituxan, that knocks out all the B cells, but at least it saves your T cells, and the T cells can do some jobs without the B cells. But the cooler ones are the most intriguing and newer ones, and ones are called complement inhibitors. Complements are a collection of proteins that get stimulated by our nasty antibody and destroy the neuromuscular junction, the acetylcholine receptors, and just do a lot of damage. They do something called muscle membrane lysis, which means they just schmuck things up. So we now have drugs that work on complement, and they are much less likely to cause immunocompromise and cancers. And now we even have a farther advanced one. We have these neonatal FC and RN antagonists, big long word. Basically what they do is they stop IgG, which is the AChR antibodies immunoglobulin, from living. They just shorten their lifespan, and so there's less IgG. So these medications actually cut down the number of AChR antibodies in half. Complement inhibitors, the ones that work by blocking the complement and the damage can be done, include IV Soliris and Ultomiris. These are super expensive drugs. Ultomiris is every 8 weeks, so it's more convenient. Zilucoplan is subcutaneous, which means you can inject it under your skin yourself. Because one of the problems with many of these medications, you have to go to infusion centers or at least doctor's offices. If you can do it yourself, it's a lot easier. For some reason, complement inhibition really puts you at risk for meningitis. So you need meningitis vaccines. There's actually 2 meningitis vaccines, one called Menactra and one called meningitis B. I'm a big pro-vaccine person. I wouldn't have any problem with people with myasthenia gravis who are on immunosuppressants of any kind. All the vaccines that are appropriate, that are safe, you should have. It's hard to get the drug because it's so expensive. In some of my webinars, the general consensus of these guys smarter than me is it sometimes isn't as effective as Vyvgart, but for others it can be very effective. And then Rituxan is a drug for the less common form of myasthenia gravis, the MuSK antibody. So like acetylcholine receptors, MuSK attack neuromuscular junction too. And it's nastier disease, and so it can cause a lot more symptoms. But Rituxan's pretty effective. Rituxan is an IV administered drug that does have side effects, but is relatively safe. Okay, so what about Vyvgart? It's a neonatal FC receptor inhibitor. It works very, very well for myasthenia gravis. You have to understand about our disease. It's 50 per 100 it's 5 per 100,000. There's no more than 80 to 100,000 people in the entire United States with myasthenia gravis. In the community of Lansing, there might be 15 or 20 of us. So it's hard to get enough people around to actually do research and appropriate evidence-based medicine studies, but they've done some very good research with Vivigard. It does reduce Ig antibodies, including AChR. You have to be AChR positive. Again, very expensive, IV or sub-Q. So there's now a sub-Q version, which still right now has to be administered in a doctor's office or a infusion center, but eventually I think you'll be able to do it yourself. So who should take Vivigard? I think that in these days, based on the fact that it reduces the actual acetylcholine receptor antibody and is otherwise relatively safe, I think it's an excellent choice. The newest one is called Ristigo. It's also subcutaneous. There's not a lot of data out on it yet, but it's probably going to be similar in its effectiveness. Some of you might find this slide particularly and some of the other slides useful. You can just ask MGMI, and they will send you a copy of this PowerPoint. This particular table goes through all the medications that we use to suppress the immune system, what the frequency is, what the benefit onset is, and the side effects. So that's about medications. Now, the rest of this talk is kind of goes back to me being your primary care person, your family guy person, and looking over not just the fact you have myasthenia gravis, but the whole you, everything about you. And this slide's kind of a tough sounding one. It says 80% of what goes wrong with with our health is avoidable, sort of to say our own fault, which sounds like a kind of quite a criticism, but actually that's lucky because we have a roulette wheel in the sky disease, myasthenia gravis. None of us did anything wrong to get MG. And we can take care of almost everything else. We can do something about avoiding the 80% so we can be prepared for the 20%. And the key components are being medically literate and controlling comorbidity. So what is comorbidity? It is a medical term for what else is wrong with you despite this, in addition to what we're talking about, in this case, myasthenia gravis. And it's profoundly important to how well you will do with myasthenia gravis or any disease. Examples include high blood pressure, obesity, smoking, which of course none of us should do, and diabetes. And so much of this relates to especially prednisone side effects. And if your A1C, I'm not a person who likes to harp and encourage use of branded drugs, but if you have an elevated blood sugar, even if it's just pre-diabetes, and you have a significant weight problem, some of these newer drugs, the Ozempic, Wegovy, Monjory, the ones you see on TV, will reduce your weight, which can be really, really hard. It's hard to lose weight when you're at a certain age. It's hard to lose weight for anyone. It's hard to lose weight when you have some muscle weakness. And these drugs are not easy to get. They're not very cheap. In fact, they're expensive. But working with a dietitian is extremely important. Working towards fruits and vegetables and less of everything else and being fit is extremely important. This slide is scary, and this is not myasthenia gravis, but this shows you the devastating effects of being medically illiterate. In this particular disease, those who were illiterate had twice the death rate of those who were literate. Those who understood the disease completely, those who understood the key components of general health, who knew when to get their vaccines, who knew about the preventive screens for cancer, who knew their numbers, who could go on their portals and understand their labs. If not, then find someone who can help them. It's absolutely essential to become medically literate. And if you are, then you form an effective partnership with your doctor, where you are prepared, where you come in and you feel almost an evenness, that you're working together, except one of us has to be in charge, me and my patients, and I'm hoping it's them. I'm hoping they've done their homework, that they have the assertiveness, that they are so energized and motivated, so caring about life, they want to be in charge. And they can be a partner in the decision-making. And therefore, you always come prepared. You have all kinds of questions. Yeah, I know the doctor's running behind. After you're done, you're probably going to run farther behind because you do not leave until all your questions are addressed. And I believe in evidence-based medicine and having all your tests thoroughly explained and risks and benefits of treatment thoroughly explained. So you know you are on a regimen, a program which has evidence to support it. In addition to literacy and managing your comorbidities, among them is relaxation and rest. I'm learning how to practice deep breathing. I'm pretty now good at quality sleep. It's super important. And the letting things go, let it be, let yourself forgive and appreciate everything in life. Be grateful. Keep a positive attitude. Lead a purposeful life. Is so, so important. And it is important for you and for everyone around you. Here's an intriguing concept. It's called know your canary in your coal mine. Now, being a coal worker is a difficult job. And one of their hazards is carbon monoxide poisoning, which is odorless and invisible and indetectable. So they actually put canaries in the coal mines, and when the canaries died, they knew they had to get out. So this is your warning. For me, it used to be double vision. I'd just be driving down the road and boom, I got double vision again. So I'm going into relapse. That was kind of distressing. Now it's my raspy voice. So it's a little bit raspy now, but if I relax after this, I will avoid it. This is actually, if Mestinon works for you, this would be a good time to take it and relax and rest. Now, vaccine is a complicated issue with autoimmunity, and especially with some of the newer medications, but it's essential. Infections are the #1 trigger for myasthenia gravis in relapse. They are safe if you take the right kinds. They are possibly not as effective because you're suppressing your immune system. And for example, with Vivigard, which knocks down IgG, well, IgG are the those are the antibodies you're trying to make against certain diseases, but you still need to do them. Keeping up to date with COVID vaccines, last week I got 3 shots in the same arm. I got my COVID bivalent booster, which is my 7th one. I got my high-dose flu shot. By the way, this flu shot this year, the most prevalent strain is H1N1, and the flu shot is kind of dead on, so it's an excellent flu shot this year. I also got an RSV vaccine, a nasty respiratory virus, not only for me, because I'm not that young anymore, but I have little babies that I might want to have fun with, and they are at super high risk. And yeah, actually, I wouldn't have any problem with just getting meningitis vaccines, even if you're not on a complement inhibitor, and if you need pneumonia vaccine. So you kind of need a primary care interact to make sure you have all your vaccines. What you can't have are the non-attenuated, the attenuated or live vaccine. But those are mostly childhood ones, measles, mumps, rubella, chickenpox. But you cannot have the flu mist, the nasal spray. You have to have the shot. So in addition, you have to be smart enough. And again, this would be the reason to request this handout, is to understand what medications to be careful of, because doctors aren't going to remember everything. I didn't put it on there, but one interesting one is statins, like Lipitor, rosuvastatin, or Crestor. I did a lot of reading on it, and by and large, I don't think statins exacerbate MG. But if you start on a statin for your cholesterol, you should be cognizant of the fact that it could possibly affect your myasthenia gravis. So I think the likelihood of that is extremely small. Okay, going back to that prior slide when I talked about acetylcholine receptors, on the muscle side of the neuromuscular junction, not on the nerve sides, like, basically nerves don't regrow, muscles regrow, muscle receptors regrow. You can build new AChR. And this is I think, the key to my doing well with my myasthenia gravis, is I understand the need for it. And I understand that it's after my relapses, when I'm rested, I need to start exercising and focusing on aerobics, using light weights, build up slowly, in addition to optimized nutrition and periods of rest. And this is a tough rule. Almost seems kind of mean, but I don't know. I think we need to do it. 350, which is the number of days a year that you exercise. Now, doesn't mean you go to the gym and go nuts and sweat and try to be Arnold Schwarzenegger. It means that you do something, that you get out, especially outside, as a way to, I mean, that's how our brains work. That's how we figure things out. That's how I learn gratitude. That's how I learn acceptance. That's how I let it go. That's how I let it be. That's how I appreciate my life. So I'm not in a position right now where I'm in a relapse and I'm feeling healthy. But even in those times when I wasn't so well, I did everything I can to get outside and move. A cyclist, but any of the, the swimming, jogging, walking are great, especially being outside. And lastly, this is my daddy over there behind the wine bottle. This is before he passed in 2016. And this is family and friends gathering around, and their support and your support of them, those connections are so important. And that is definitely one of to me, the key parts of living long and living well. Thank you very much.
Thank you, Doctor.
Any questions?
Yes, thank you. Dr. TePastte, we have two questions. And the first question that was posed is, one of the presenters yesterday mentioned vitamin D level. Can you speak to that, please?
Yes. So vitamin D is a vitamin that helps fix healthy bones. And it also helps your immune system, and it's associated with general health issues. So it's important to know your vitamin D level. And vitamin D can be, if your level is low, you can take vitamin D supplements. They work fine. They're inexpensive. They're over the counter. Vitamin D is also promoted by the sun. So anyone who's out in the sun, you have to kind of you can still use sunscreen. You'll still get vitamin D. So as a person with myasthenia gravis who is at risk for thin bones, and in general, those of us who have caring about our health are going to want to have our doctor draw our vitamin D level. It's a simple blood test. And if it's low, the treatment is easy.
And any relation to myasthenia?
I don't think so. I mean, not that I'm aware of.
But general health, as you were discussing, which is
Correct,
really important.
yes.
Okay,
Yes.
great. And the next question is, how often do you need to get the meningitis vaccine when you're on Alzheimer's?
5 years.
Every 5 years. Okay.
Yep. That's Menactra and meningitis B.
Okay. And I know that for my insurance, sometimes I have to show that I've given it before they'll pay for the medication. Okay.
So, I mean, that's a simple thing to do. And Alzheimer's is an amazing medication. Yeah.
Okay. What about the shingles vaccine, Shingrix? Is that important to get?
It's very, very important to get. And Zostrix, which firstly didn't work. So many of us got 2 Zostrix followed by 2 Shingrix because the Zostrix didn't work. And Zostrix was a live vaccine. Shingrix is not live. Shingrix is safe. So everyone should get Shingrix. Herpes zoster or shingles is horrible.
Yeah, my doctor, Dr. Tiener, had said to me, you know what, if you're going to be picking and choosing, get Shingrix, because he said that neurologically he treats every kind of complication, but it's a struggle sometimes with the post-herpetic pain, he said. So that's one that he selected for me. Okay, here's another question for you. With the censoring of medical data by government agencies, how can you get accurate information on drugs or treatments?
Well, there's that, and there's also Dr. Google. And you got to be careful about Dr. Google. My best advice is the people here and your societies, the MGA of Michigan, the National MGA Foundations, and evidence-based medicine can be found. I mean, there's a website called Up to Date, but you have to pay for it. But it's got the very, very best information for patients and physicians. So what you might do is get your information, and then have your physician go over it with you, and confirm that it's medically valid and evidence-based. But so it's there's all kinds of. I try. I'm not necessarily opposed to complementary medicine, where people take a variety of somewhat unproven product supplements and whatnot, as long as they don't interact or interfere with the actual evidence-proven medicines. And there's a placebo effect, which is fine. I mean, if you think something works, and it actually works, even though it doesn't work. So I think that I've seen literature when I was at the conference in Lansing that looked really top-notch from this organization, and that would be my starting point.
Okay, the person asking is a veteran researcher on myasthenia gravis, everything and treatments, and it is an important question. I try to go to something that's been peer-reviewed, meaning there's been a study published, and the other people in the field have had to comb through it and validate it, but still that might not be, it's not as timely. It's not sometimes real-time information.
And getting back to the 80, there's only 80,000 of us. You're trying to put a study like Vyvgart study. There weren't that many participants because there just aren't many of us, and there just weren't many people willing to do it. And apparently, the neonatal receptors might be useful for MuSK, but there's like 3 people who had MuSK in the study. So we're just going to sort of have to be semi-guinea pigs, because we're not going to get the sample size that most other diseases get. But we need still the best science we can have before we start something new.
Okay, we have 2 minutes left, and I like to prioritize other people's questions, but I do have a question for you, centering around a statement you made at the very beginning of the slides when you were talking about your thymus started putting out antibodies that were aberrant. And I just wonder, is there a lot of research that ACH receptor antibodies, are they pretty certain that that's some kind of misfiring by the thymus gland as opposed to other?
No, the ACH antibody was accidentally created by your immune system by the B cells in your bone marrow.
Okay.
The thymus is T cells, and T cells act on behalf of B cells. The B cells identify the foreign invader, vitamin, bacteria, et al., and the T cells kill them. So the B cells are where the antibodies come from. There are no antibodies for T cells, but the T cells are supposed to respond appropriately and either kill the organism or help other cell types kill the organism. And the thymus is not normal in people with myasthenia gravis, whether you have a thymoma or not, because the T cells don't perform properly. And taking the thymus out, you shouldn't do it when you're just a baby or a young child, when it's having to do its job of maturing T cells. But later on in life, appears to be totally safe and is not immunocompromising.
Okay, thank you so much for clarifying for me. And I'm going to turn the program back to Susan now. Thank you, Dr. TePastte. Fantastic info in real life,
Thanks.
Yeah, really, really fantastic presentation, Dr. TePastte. I think that the important thing is you yourself with getting, having RSV and, it triggering that. I think that unfortunately we're in the age where there are things out in our communities that are dangerous, whether we know them or not. And I think that figuring out a way to get the vaccines in order to be able to prevent you from, or using the best method to prevent you from getting those. I know that after some people had COVID, they also then got RSV. And a couple of them were triggered with MG. Those were patients, and there was an MG registry for people who got MG after they had COVID. So, there are things out there, and being able to make sure that you're preventing that. I really appreciate you talking about it, and also being able to, share the presentation about general health